Welcome to our in-depth exploration of Truncus arteriosus, a rare and complex congenital heart defect. In this video, we will delve into the causes, mechanism, symptoms, diagnosis, treatment, and long-term outlook for individuals affected by this condition. Join us as we unravel the intricacies of Truncus arteriosus and shed light on the advancements in its management. The exact cause of Truncus arteriosus is often unknown, but it arises during fetal development, specifically in the early stages of heart formation. Typically, the heart starts as a single tube that divides and twists to form the separate arteries, the aorta and pulmonary artery, and the ventricles. In Truncus arteriosus, this process goes awry. Genetic factors and chromosomal abnormalities like Dijk's syndrome or 22q11.2 deletion syndrome are strongly associated with increased risk, suggesting a genetic predisposition. Environmental influences and maternal health conditions during pregnancy may also play a role, though further research is ongoing to fully understand these complex interactions. In a normal heart, the aorta carries oxygen-rich blood to the body, and the pulmonary artery carries oxygen-poor blood to the lungs. But in Truncus arteriosus, instead of two separate arteries, a single large vessel, the Truncus arteriosus, arises from both ventricles of the heart. A ventricular septal defect, or VSD, almost always accompanies this condition. The VSD is a hole between the ventricles, allowing blood to mix between the right and left sides of the heart. Consequently, both oxygen-rich and oxygen-poor blood mix in the Truncus arteriosus, and is then distributed to both the lungs and the body. This abnormal mixing and increased blood flow to the lungs places a strain on the heart and lungs, eventually leading to heart failure if left untreated. Truncus arteriosus is a relatively rare heart defect, accounting for approximately 1% to 4% of all congenital heart defects. This translates to approximately 200 to 300 cases per year in the United States. There is no known racial or ethnic predilection, and it affects males and females equally. Due to advances in prenatal diagnosis, many cases are now identified before birth, allowing for improved planning and management strategies. The signs and symptoms of Truncus arteriosus typically appear shortly after birth. Common signs include cyanosis, a bluish tint to the skin, lips, and nails, caused by insufficient oxygen in the blood. Infants may experience shortness of breath or rapid breathing, poor feeding, and failure to thrive. A heart murmur, an abnormal sound heard during a heartbeat, is almost always present. Over time, if untreated, these symptoms can worsen, leading to pulmonary hypertension, a high blood pressure in the lungs, heart failure, and increased susceptibility to respiratory infections. Diagnosis of Truncus arteriosus often begins with a physical examination, where a doctor may detect a heart murmur and observe signs of cyanosis or respiratory distress. An echocardiogram, a non-invasive ultrasound of the heart, is the primary diagnostic tool, providing detailed images of the heart's structure and blood flow. Other diagnostic tests may include an electrocardiogram (ECG) to assess the heart's electrical activity, a chest X-ray to evaluate the size and shape of the heart and lungs, and cardiac catheterization, a more invasive procedure that allows direct measurement of pressures and oxygen levels within the heart and blood vessels. Genetic testing may also be performed, especially if there's a suspicion of an associated syndrome like Dijk's syndrome. Historically, Truncus arteriosus has been classified according to the Collett and Edwards classification system, based on how the pulmonary arteries arise from the Truncus arteriosus. Type I is where a single pulmonary trunk arises from the Truncus arteriosus and then divides into the left and right pulmonary arteries. Type II is where the left and right pulmonary arteries arise separately but close together from the posterior aspect of the Truncus arteriosus. Type TT is where the left and right pulmonary arteries arise separately from the sides of the Truncus arteriosus. Type IV, now considered a severe form of tetralogy of Fallot with pulmonary atresia, involves absent pulmonary arteries, with blood supply to the lungs coming from collateral vessels from the aorta. In contemporary practice, this classification is less crucial for surgical planning, as surgical repair generally involves separating the pulmonary arteries from the truncus and connecting them to the right ventricle with a conduit. The primary treatment for Truncus arteriosus is surgical repair, typically performed in infancy. The goal of surgery is to separate the pulmonary circulation from the systemic circulation. This is achieved by closing the ventricular septal defect with a patch and creating a separate pulmonary artery using a conduit, a prosthetic tube, to connect the right ventricle to the pulmonary arteries. The Truncus arteriosus then becomes the aorta, carrying oxygen-rich blood to the body. In the immediate postoperative period, infants require close monitoring and may need medications to support heart function. Over time, the conduit may need to be replaced as the child grows, requiring additional surgeries. Lifelong follow-up with a cardiologist is crucial to monitor heart function and detect potential complications. Unfortunately, there is currently no known way to definitively prevent truncus arteriosus. However, optimizing maternal health before and during pregnancy is crucial. This includes avoiding alcohol and tobacco, managing pre-existing medical conditions like diabetes, and ensuring adequate folic acid intake. Genetic counseling is recommended for families with a history of congenital heart defects to assess the risk of recurrence and understand available prenatal diagnostic options. The prognosis for individuals with truncus arteriosus has significantly improved over the past few decades due to advances in surgical techniques and postoperative care. With timely surgical repair, most infants can survive into adulthood and lead relatively normal lives. However, long-term complications such as pulmonary valve regurgitation, conduit obstruction, and arrhythmias can occur, necessitating ongoing monitoring and potential re-interventions. Recent research focuses on improving conduit designs, minimizing the need for reoperations, and understanding the genetic basis of truncus arteriosus to potentially identify at-risk individuals earlier. Additionally, studies are exploring the use of percutaneous valve replacement techniques to avoid open-heart surgery for conduit replacement, offering less invasive options for long-term management.